Welcome to How to Grow as a Medical Educator, a Learning Lab podcast recorded in the Stanford Medicine studio. In each episode, we talk with faculty who are actively experimenting, reflecting, and evolving in their teaching. Our goal is to surface the stories, habits, and practical strategies behind their growth so that medical educators everywhere can learn alongside them. Let's get into today's conversation. Today, we are joined by Dr. Rebecca Miller-Kuhlmann, Assistant Dean for Pre-clerkship Education and Clinical Associate Professor of Neurology and Neurological Sciences here at Stanford University School of Medicine. Dr. Miller-Kuhlmann brings a highly unique perspective to medical education, having started her career as a K-12 public school teacher before pursuing medicine. Today, she applies her formal pedagogical background to shape how the next generation of physicians learn, communicate, and thrive. She earned her MD with distinction from UCSF, where she completed the Health Professions Education Pathway and completed her neurology training at Stanford. So welcome.
Thank you.
I'm also joined by my colleague, Adam Hain.
Hello.
Hi, Adam. He is our Learning Design and Production Director here at EdTech. Dr. Miller-Kuhlmann, could you please share a bit about your background and how you found your way into medical education?
So, yes, I can. Before I went to medical school, had my secondary science credential for grades 6 through 12, and I taught 8th grade science across the Bay in Oakland. So my days before medical school were, a true 8 to 3, I think was the schedule of teaching the same class 4 times a day. And then I dabbled in some other things like art and advising for 8th graders. And so when I went to medical school, I really thought I was career shifting. I was taking education, putting it aside, and I was focusing on medicine. And then the opportunities to teach kind of surprised me, even during medical school, which our students could speak to as well, right? There's a lot of opportunities for peer teaching. I ended up agreeing to teach post-bac students when I was a third-year medical student, and just really enjoyed it and really enjoyed the combination of pulling those skills that I had kind of let be dormant into this new context. Mm-hmm. And so that's definitely continued as a theme for my career.
Yeah, I love that, just kind of that continued passion for education. And so you oversee the pre-clerkship curriculum. You teach the Science of Medicine course. You're also, you teach neurology as well. And so you're really covering such a significant amount of pre-clerkship content. And so I'm curious, from an instructional design perspective, how do you map and scaffold that much information, a lot of it scientific and dense, so that students can really sort of get the information they need with the right sort of scaffolding and timing?
Oh, it's such a good question. It's a group project in the best of senses, in and of that we have, I think I told you recently, over 1,200 hours of content across the pre-clerkship. And so it is not a job for one person. And many hands certainly make light work. And then there's also the structure of making sure all of those hands are talking to one another. So, definitely some of the things going back to that K through 12 of really understanding our institutional objectives, our course objectives, and unpacking those to session objectives and doing the work of making sure that we're teaching what we intend to teach and then we're assessing what we teach is a huge undertaking. So we have entire systems to map it, but then we are also working on the one-to-one level, each of our block directors. And I will say I have the privilege of working with such incredible educators, some of whom I think you probably have or will have on this podcast. They all have a sense of their material, and we look at what best practices are across different blocks and chunks of content, but then also how that applies to them. And there's no one size fits all, which is both the joy of it and also the challenge of it. But so we make sure that we have a map and that we also make that map accessible to the students for every block of content. And then we constantly hearken back to those maps during each, 4 to 6 week session that's focused on a particular topic. Mm-hmm. And then my job is then to take a step back even further from that and look at all of those maps and say, how do we figure out gaps? And that's really where a technology piece and partnership and being able to search and to analyze for where are we teaching twice, where are we missing something is so important.
Yeah, I'm just hearing a lot of transparency in design and sharing that with the students, and then also the communication piece across all of the faculty, and just, yeah, trying to get that breadth and cohesion across all of the courses.
Yeah, I think the only other thing I'd add is like it has to be a living, breathing thing. Like it's not something that you do once. It's something that we
Right.
have to harken back to again and again and take a step back and be like, what's changed? What are we teaching that's outdated now? What are the new things like responsible usage of artificial intelligence that we need to make sure our students do know? And as we pull things in, what goes out? So there's a lot to think about. It's very fun.
Yeah, it's less than being sort of this like linear process, or even like a grid. It's like spirals,
It's
many different
definitely
spirals.
spirals.
Yeah. Neat.
For sure.
We've talked about this a lot, but um, a lot of medical education, especially in pre-clerkship, is largely lecture-based. But there's a lot of instructional design and learning theory that shows that other modalities can be more effective. How do you approach like bringing in more interactivity or modalities that bring more engagement to learners while keeping sort of that lecture kind of content train going?
It's such a good question. It's such a good question. And it's a huge tension because teaching, if we want to do the active reinforcement, the active learning where the students are taking material they've learned and grappling with it and reasoning it and applying it, they still have to learn the content, to be facile with it. And it takes time. And we're doing this, in this bigger system where the pre-clerkship space, and we have our 4 years of medical education, in most places nationally is getting shorter and shorter because of increasing demands on clinic and some other logistical things about how our students apply to residency and those timelines. And so we're being asked to teach more interactively, but also in less time. And I will tell you before before actually getting to your question, that one thing I try really hard to avoid is the magical thinking that they can come in and interact with the material before they've learned it. Like the time still has to be there for them to learn it, whether it's in a lecture, but we're trying to condense that lecture and make it as high yield as possible, or whether it's in a module that they do asynchronously. Like that time still has to exist for the student. And our students are also pragmatic and, using their time for many different things. So I do, for right now, have a very, I guess pragmatic is probably the word, approach to this, where if we're going to make it interactive, it should be something that like needs to be in person. It's worth the time. It's worth the recruiting, 8 faculty facilitators to have students in small groups to do something where there's something very interactive, for example. If it can be an asynchronous module, it should be a module. If it needs to be taught in person in like a semi-interactive way, I actually think that there's a lot we can do with lecture or in a classroom space that is neither fully flipped classroom nor fully lecture, right? And that's almost the space that I think logically it makes sense to lean into and optimize when I look at the whole system.
Yeah, I mean, I like what you said too about it being part of a larger system. So it's not like the students aren't getting an opportunity for applied practice. They're getting it in clerkships, in POM and things like that, practice of medicine. And I think there was like this idea a few years ago in educational research that like all lecture is bad somehow. But it kind of, I think about it like it depends on what your objectives are and like what level of Bloom's taxonomy or whatever that you're kind of aiming for. If it's the lower levels, lecture might be the best way to get those things to learners.
And I think the other question is what's replacing the lecture, right? Like if it's something that the students are doing at home in their pajamas, like you're losing out on the the classroom as a dynamic environment, the possibility for peer-to-peer teaching, the interaction and the mentorship between students and faculty, the asking of questions, which is why, the flipped classroom space is so appealing, because you keep those strengths of the classroom, but you have the students sort of magically learn a lot of the material beforehand somehow so that they can come in and apply it. And it is a magical space, but I think it still takes twice the time. Right. I don't think that you're replacing teaching with application. I think that they both still have to exist for the learner, and probably someone with deeper education theory than myself might have more to say on that. But to me, they still have to learn it. And we know from some of our peer institutions that went to all flipped classroom, or that did say death to the lecture and got rid of them all, that then the students were like, but I want you to teach me. Yeah. I still need to learn it. How do I learn it? Yeah. I don't want to learn it all on my own. I don't want to take a correspondence course in medicine.
Yeah, and we've had some of that feedback here too, I think, where there's been student resistance when we've gone too far into the flipped classroom modality sometimes. Not everybody loves it.
No, I mean, the tension we have now is we are largely lecture-based for when we're teaching the medical content, but even within that, we have intermittent reinforcement sessions where the students come in small groups and run labs. They see the path specimens of the organ systems that they're working with, and they do cases that relate to that. And then our whole afternoon in the practice of medicine is largely application. The clinical reasoning, the things that you need to lay hands on a patient, the things that are conversational, it makes so much sense for that to be in-person, active, and dynamic.
Yeah. So. And I mean, it would be hard to have the entire day be active and dynamic across the whole week.
I can imagine the learner feedback if we went in that direction. Here's 8 hours of active learning for you.
Yeah, it's so important to also, like you've acknowledged, just the time constraints. And there's so much information and engagement, but there's also less and less time. And so trying really to make it as effective as possible is a big goal and challenge. Yeah.
It really is. Yeah.
Could you share a little bit more about the neurology labs that you've developed in those small group discussions, and like sort of how you think about which content is best for those discussions, or how you've designed some of those?
Sure. So within our neurology block, so this is teaching really the core pathophysiology of neurologic conditions. And then again, remember, they're getting their practice of medicine course separately, where they're learning the exam skills and doing some patient interviewing and some specific clinical reasoning cases. We look at what are the conditions that we're teaching in lecture that then we can then reinforce in a totally different way, in an active way, where we're pulling a bit from that afternoon curriculum with clinical reasoning. We're also pulling from our path counterpoints and our radiology counterpoints and making it alive in a patient case. And we have to be very careful about what we choose, because in 2 hours, we often cover 2 or at most 3 cases. And, this is for 30 hours of lecture content. So we choose the things that we think, no matter what the student goes into, we want them to recognize this condition. We think about the things that are important. We also think about the things that are board testable, and we think about them in that order very specifically. The wards, to us, the most important thing, and I try to put this centrally whenever I'm thinking about anything in education, is our goal is to make excellent doctors. Like, that is the goal, right? At Stanford, we have a dual goal of excellent doctors and excellent scholars, but in terms of the curriculum, excellent doctors. And then, of course, those excellent doctors have to pass their boards, and they are so worried about them. And we have to acknowledge that pressure upon them. And in an ideal world, the boards and the wards would be an overlapping circle. Passing this test and being an excellent doctor would be the same. But we know that we can't test our way to greatness in person in a human profession. So all that to say, for our cases, we look both at things that are highly clinically relevant and highly boards relevant, and especially if we find one that's both, that's what we choose to be those reinforcing sessions where we're really underscoring it and having that moment in smaller groups. And then again, we have an amazing pathologist counterpart who's bringing in brains so that they can actually also feel the pathology, see the pathology, and really understand what's going on inside the skull.
Nice. Yeah.
We're talking a little bit about bringing some of those active learning approaches into lecture classrooms, and I think this is a good example what we've been talking about of having these case-based discussions that are the session is all active and the lecture can maybe be less so where it's more content driven. But what are some strategies for getting faculty? You lead the pre-clerkship, like overall, and the science and medicine course, just for getting faculty to use some of these interactive tools, either in the classroom or in like the LMS, like Canvas or something like that, because tend to have little uptake, I think, on some of those.
The main strategy, I think I'm going to say the word pragmatic too many times while we're talking, but things that don't take an exceptional amount of time and have very little friction are what faculty are able to do. Like the reality is
things that work.
things that work, but also and things that it's not easy because of laziness. It's easy because of the system we're putting it into. That's why it matters. I need something that can have uptake among 300 different guest lecturers so at certain times. And we also have core lecturers. That's easy. Our core lecturers are innovating and teaching me things all of the time. But our guest lecturers, who are also amazing, are coming in on their own time that they're taking away from clinic research and everything else that they're being asked to do. And so if I want them to log into a student response system and it's going to not work on their Mac because it only works on PC, or it's going to freeze the day of, or the students all have to have a separate lot, like all of those little things that seem so marginal are the friction that can kill anything when we have to think about it across the pre-clerkship. I would say on that end, one of the main things our lecturers do is, they ask questions. Whether or not it's like with a formal polling or any of the things that are fun and visual, they ask questions of the students. They pull answers. They have the students pair share. Pair sharing to me is still, Adam, you and I have talked about this before. It's like my favorite thing in the world. Or even like pair without the show, just like, or even just having a question and having them think about it, like making sure that while they're getting that material, the students are being asked to actually grapple with it actively, even when you're giving it in a PowerPoint format. And that can be having questions we're going to answer at the beginning and coming back to them and saying, so hopefully you can answer this question now, right? Yeah. And that sort of thing. Like there's very low-hanging fruit there, and it's not high-tech.
Yeah, I mean, I guess things don't have to be complicated to still be effective. The pair share thing is funny because it's like there's all these other little tricks and active learning techniques, but that's like the first one that you learn about and just always works.
And it works. And so exactly.
You mentioned the guest lectures, and I wanted to ask, from a instructional design or faculty development perspective, like what can we do to support those block directors that have these guest lecturers who are really amazing and doing amazing research, but aren't really familiar with the course itself? Like, how can we help to make that feel coherent to the student?
It's a huge challenge. It's a huge challenge because then we're asking them not only to donate their time, but also to donate additional time. And yet it's necessary. Things we've done over the years, we're very careful with guest lectures and making sure that for a specific topic, it really makes sense for it to come from the expert. We're also, it's a huge thing to expect experts to be amazing educators to the very novice level, because they are by definition the people that are the farthest away from the novices in terms of their knowledge base, and things that have long been easy to them are hard. We talked about my background. I remember an 8th grade lecture where I was teaching them about volume, and I was so proud of myself because I had visual aids for the first time because I was I was really growing as in my own little 8th grade classroom. And one of my lovely English language learners at the end of the whole session was like, so like the thing on the TV remote. And it didn't even occur to me that they were all anchored in volume as sound and having trouble thinking about it as a scientific concept. But like, I think about that with every lecture I do, right? Trying to go back to like, what are all the assumptions I'm making? not every amazing expert we have in this campus, which there are so many, is going to have the time to do that. So we have to have systems where we're reviewing their slides, we're giving feedback. It's expected. Like I have standards saying like, a lecture is 40 slides for 50 minutes. It's not 100 slides. And we review that and we give feedback and we work to cut things down, for example, and to help our guest lecturers to meet our structures. And so we kind of have to do that. And there has to be a culture where that's expected.
Mm-hmm.
And that's been, I think, a slow shift that certainly didn't start with me. That's been going on for many years. But we try to make sure that we bring them in and we support them in being successful because, of course, they want to be successful.
Yeah.
But it takes time.
Yeah.
And it's a different skill set.
Yeah. And I think one thing that we talked about and have tried is like the map of the blocks. So showing learners like, okay, well, this is the whole course and here's the different lectures and here's why that this lecture is in here. Like before they just show up to the lecture, they kind of know like this is intentional,
Yeah, our learners often describe guest lecturers both in terms of, oh my gosh, I got to learn from this amazing famous person, and also they parachuted in, right?
Mm-hmm.
And so like we try to stop and help with that parachute mentality where the parachuter does know exactly where they're landing, to your point. And it's an ongoing process. We certainly don't have it all figured out. There's always a tension there. Yeah.
Do you have a lot of repeat folks, or do you find that you kind of get things settled and then you shift and bring in a new person and then are sort of orienting them?
I know in a lot of the pre-clerkship, we have guest lecturers that come back year after year.
Yeah.
And so,
nice.
that's really nice to work with them because they're both getting feedback from the students year over year that the students are kind enough to take the time to give, that we can then make sure that we're working with them. And also, they know the pre-clerkship more when they're coming back. But then we also have to make space for new people, and we have turnover, and we don't want it to always be the same either. So it's a little of A and a little of B. Yeah.
I would love to talk a little bit about assessments and how you approach formative assessments or quizzes and things of that nature to gauge if a student is actually ready to apply sort of their basic science to clinical spaces and approaches.
Oh, it's a good question. The main thing that we do I think of our curriculum as the morning and the afternoons and the science of medicine side of things is we do assessments on a weekly basis. And this comes back to that tension between the ideal and the pragmatic. When I had little classes of 30 eighth graders, I would give them 2 questions on the way out the door and know exactly where I failed that day or where I succeeded. Mm-hmm. And in this case, we do collapse it into the end of each week, but we look to see how they do and they get to see how they do. And we leave them they can be open book, they can be collaborative. Like the whole point, we care more in our current curricular state, and this is totally up for debate. It's probably a hot take, but that our adult learners have been very successful adult learners up until this point. And so we want them to use those quizzes how it will best help them. So we actually do put the onus on our learners, which is why we don't say that it has to be closed book or it has to be like, right, if you work best by teaching each other, we have a whole lot of students that get together on Sundays and they do their weekly, quizzes and problem sets together versus some students that are like, no, I need to know if it's in my brain and I'm going to work alone, right? And I think both are very legitimate. What we trade off in that is getting the exact feedback of when it's collaborative, you dilute a little bit of how effective was the lecture at teaching the concept.
Right. But the learner hopefully has that pretty clear idea for themselves.
And our learners also tell us whether our lectures were effective.
There you go.
They're very motivated and very engaged, which is wonderful. Yeah.
And I think you've been leading a push towards more formative assessment too throughout the pre-clerkship, just getting more of those signposts for the learners to see for themselves, like, how am I actually doing? So it is not a surprise at a midterm or something like that.
Yeah, another hot take. I mean, I know that formative and summative assessments are very well crystallized educational strategies, but I'm not convinced that they're as separate as we view them. So, like, for example, in our courses, we moved from having all the tests at the end to having closed books rather than high stakes exams or low stakes, which we often think of high stakes as summative and low stakes as formative. We have a lot of medium stakes assessments where we're bringing them in. They're taking the exams in a closed book environment and really getting to know how they do, but they get early feedback on their study strategies and their engagement with the curriculum. So whether that's, I almost view that as some mix of formative and summative, right? But the intention of it is highly formative, to be testing them sort of early and often, so that if they're going to fail, it's in a smaller way,
Right.
and it's not after 16 weeks of curriculum that they realize their study strategy wasn't great for the piece of this material.
Right.
We want them to know that at week 4, week 5.
Yeah. That early and often and that blend of assessments, I think, is just a really strong pedagogical approach. I would love to learn a little bit more about, I know you co-direct a communication coaching program. And so before we get towards the end, I wanted to hear a little bit about if you could just share about that program and if there are different approaches that you take with communication coaching versus some of the other courses, or if there's similarities.
Absolutely. So the communication coaching program is for residents, so it's a different learner set.
Okay.
So different context. Do you want me? I'm happy to go into it. Do you want me to go into it, or do you want to stay pre-clerkship?
Oh, no,
You don't have to stay.
yeah,
okay?
I would love to hear about the.
It's like a leap into
yes.
the graduate medication.
Yeah,
space.
absolutely.
So coaching is incredible. And coaching, the expression about standing on the shoulders of giants, we have incredible, innovative educators here at Stanford that have trailblazed in coaching for residents. It started in our pediatrics department, and we in neurology and general surgery were the two places that decided to open a communication coaching program. And I honestly think we were supported in that because of the idea that if you could have an educational structure that worked in neurology and general surgery, it could probably work anywhere. Those are as different as residencies probably get. But to your question, the structure of the program is we have faculty coaches who follow our residents. They each have a cohort. They follow them longitudinally across their 3 years. So it reaches a couple educational gaps in graduate medical education in terms of longitudinal, psychological safety. It's non-evaluative, being very learner-driven. So it is based on communication, because neurology, and this applies to many specialties, but our residents, when we did needs assessments, my colleague and the founder of the program, Carl Gold, did a Rathman Fellowship and did a whole needs assessment on communication. And the residents were like, we don't know how to do a lot of the conversations with they do fine, actually. They get beautiful evals from patients, but they feel like they want more. And they wanted more education on how do we approach these difficult conversations, and how do we do it in these structures where we're constantly under time pressure? How do we have a goals of care discussion? We're dealing with neurologic disease, and we're dealing with patients with communication deficits, with cognitive deficits. How do we do all of that? It's a lot.
Yeah.
So and they asked for a coaching program. The learners came to us and said, we've heard about coaching. We want someone who's going to, so our coaches go into the clinic. The resident tells the coach what their goal is and what they're working on. The coach is a fly on the wall. And then there's a facilitated reflection, right? There's a debrief after. And then there's the ability for that. Again, it's a longitudinal thread. It's separate from evaluation. It's beautiful for growth mindset. And I mean, there's also a natural mentorship in that, but we really separate it, mentoring versus coaching. So that's probably a whole separate topic. And there's amazing people I can recommend if you want to talk more about coaching on your podcast too.
Great.
More to come.
Well, it's great to hear about that, because it sounds like just a very impactful and very positive experience for the students, and certainly something that's very much needed. So that's great.
It's a hugely powerful educational tool. Yeah.
Wonderful. Do you want to ask the last?
Yeah, we're getting a little shorter on time, but one thing we wanted to ask is what's one thing that you wish instructional designers, curriculum designers, or media production folks like us could do to support you or your colleagues in bringing these courses to life?
Oh, Oh, it's such a good question. Just take everything you do and make it very practical and scalable, and think
Pragmatic.
about be pragmatic, be pragmatic. That really is it, though. There's so many amazing tools that I look at, but there's something about it that it's just too clunky to really scale and to use. And so make it take 80% of your effort and think about how you can make it highly usable and scalable with everything you do, because everything EdTech, for example, does is amazing. And some of the most impactful things are there. I mean, it's the technological version of the pair share. It's the thing that you can do that's just applicable everywhere, that's easy to implement, and that's such a high bar when you're talking about technology. So it doesn't quite answer your question.
No, I mean,
but
that's a really key thing to think about, because sometimes, we might be thinking like, what's going to have the best features or have the most flexibility, but I think putting simplicity first, considering the audience of faculty, is really important to keep in mind.
Yeah, and of course, I'm speaking from a perspective of thinking about 1,200 hours of curriculum. Someone who's doing, it's clearly different, like the coaching program, when we're talking about 40 learners. It matters. There is certainly a place for more complex things that are really niche, but in terms of the more broadly you want it to apply, just the simpler and the easier to use and the less friction to implement and to train on it, the better.
Yeah. Seems like reducing friction is a benefit in any modality and experience.
100%.
Well, thank you so much for joining us today. We've really enjoyed having you. Thank you for joining us for this episode. If you'd like to explore more conversations like this, you can find our episodes on the EdTech YouTube channel, major podcast platforms, and in the Stanford EdTech newsletter. To learn more about our work with faculty and educational technology at Stanford Medicine, visit our EdTech site at med.stanford.edu/edtech or reach out to our team. We'd love to hear what topics you'd like us to explore next. Join us next time, and let's connect in the Stanford Medicine studio.